All right, so this is the super condensated, highest yield stuff from the hand section. Remember the brachial plexus. I'm not going to play the movie. Remember, you can learn any way you want to. I found this extremely useful. Learn it, know how to do it. Do it a few times the day before. Do it that morning. Make sure you're doing it right. As soon as you sit down, draw it down. And I can guarantee, no one else can guarantee you this. I guarantee you some answers. The scapholunate ligament, we talked about the intercarpal ligaments, scapholunate and lunotriquetral ligaments. They're the primary stabilizers of the proximal carpal row. Each has 3 parts. If you tear your scapholunate ligament, you end up with a dorsal intercalated segment instability deformity, the DC deformity. If you end up with a LT injury, you end up with a VC deformity, the volar intercalated segmental instability. Each has 3 parts. For the scapholunate ligament, the dorsal part is stronger than the other 2. For the lunotriquetral ligament, the volar third is stronger than the other 2. Basal joint of the thumb, the most common form of arthritis that we see in the hand. The thumb Cmc joint, the primary stabilizer, is the volar beak ligament, and we feel that attrition of this ligament is what leads to degenerative changes. Nerves, all sensory axons, have their cell body in the dorsal root ganglion. The 3 main nerves that make our hands function is the median, the ulnar, and the radial nerve. All 3 nerves enter the forearm through muscle intervals. The median through the superficial and deep head of the pronator teres, the ulnar through the superficial and deep heads of the flexure carpi ulnaris, and the radial through the superficial and deep heads of the supinator. In the palm of the hand, the artery is volar to the nerve. In the fingers, they flip around, and the nerve is volar to the artery. The radial nerve innervates the brachioradialis, the ECRL, and cuneus and ECRB. The posterior interosseous nerve, the order of innervation is, as you see right there. This is critical in the sense of recovery of muscle function after a radial nerve injury, especially in the setting of a humeral shaft fracture. Again, you need to know this. Intrinsics, there can be anomalous extrinsic. The most common anomalous intrinsic is the extensor digitorum brevis manus, which can appear as a mass on the dorsal aspect of the wrist, very commonly confused with a ganglion. If it's painful, you can remove it. As far as the wrist flexures, the FCU, or flexure carpi ulnaris, is the primary flexure of the wrist. The pisiform is its sesamoid. The flexure carpi radialis has multiple and varied insertions, including into the index and long metacarpals, as well as the trapezial tuberosity. Flexure sheath of the tendon, there are 5 annular pulleys, 3 cruciate pulleys. A2 and A4 originate from the bones, from the proximal and middle phalanges respectively, and they are mechanically the most important to prevent bowstringing of the tendon. Flexure lacerations in the palm of the hand. All of these injuries have to be treated surgically in the operating room. On examination, you will see loss of cascade. As you see in the picture right here, the ring finger has a laceration of the palmar aspect, and there's a loss of the cascade of the digit, and that should tip you to the presence of a tendon injury. Any injury more than 60% of width, I would say 50 to 60, should be repaired. Otherwise, especially if there is triggering due to the little piece of tendon that is flopping around, those have to be trimmed. Avulsion injuries, zone 1, meaning at the point of insertion of the flexure tendon into the fingertips. These are avulsions from a distal phalanx. They are classified by the Leddy classification, which is helpful not only in description but also in treatment. This classification is one of the ones that the lower number is worse. Type 1, the tendon retracts into the palm. Type 2, the tendon retracts to the A2 pulley. Type 3, it retracts into the A4 pulley, and that's typically associated with an avulsion fracture. The problem, the ones are such a problem, is remember that the flexure tendon nutrition comes through synovial fluid in the sheath. If the tendon retracts all the way to the palm, it doesn't get its primary source of nutrition, and as such, it's dysvascular, can contract, and as such, any Leddy type 1 injury has to be repaired within 9 or 10 days following the injury. Repair facts following flexure tendon repair of the hand. The main or the best construct for these repairs are core sutures in combination with epitenon sutures. Remember that stress at the site of the repair increases content and organization of the collagen molecules. Repair strength is proportional to the number of core sutures and the caliber of the suture. You should have equal tension across all strands, and dorsal placement is biomechanically stronger than volar placement. Rehab facts, again, either actively or passively, the frequent application of stress is key to organize the collagen. If you have an active mobilization protocol post-op, the risk should be an extension and the MP joints inflection. Active motion protocols can lead to an increase in tendon excursion. Most of these should start rehab or therapy within 1 week following repair. If you have a child that cannot cooperate with a therapist or a splinting protocol, the kids should be casted for about 4 weeks after repair. Complications after zone 2 injuries are joint contractures. If you get adhesions that fail to respond to conservative treatment with therapy, a tenolysis after 3 to 6 months can be helpful. Rupture of the repair is common, mostly due to aggressive use of the hand or poor compliance. It can be difficult to differentiate from adhesions, and as such, ultrasound or MRI can help. If you have established the presence of a re-rupture, obviously surgical exploration and repair is the key. Moving on to extensor injuries, remember the zone 3 is the dorsal aspect of the PIP joint. These are central slip injuries also that eventually lead to butt near deformity. These injuries constitute loss of continuity of the central slip. Patients will come in with lack of active extension and a flexion posture of the joint. Like all other tendon injuries in the fingers, extensor tendon injuries, closed injuries treat closed, open injuries treat open. If you have a closed injury, then you treat it in a splint, in a PIP extension splint with DIP movement for about 6 weeks. If you have an open injury, like in that picture, then those should be treated with exploration and repair. Early recognition of the central slip injury is important. Weakness in extension against resistance is a way to do it or measure it. Decreased DIP flexion with the PIP joint held in extension. And finally, 15 to 20 degree loss of PIP active extension with the PIP and the wrist and the MPs fully flexed. Sagittal band disruptions are key. These can be either due to lacerations or a blunt injury to the MP joint. The most common type of sagittal band injury is the radial sagittal band to the long finger. Acutely, you can try to treat this with a splint or a cast. More chronic cases or unstable cases have to be repaired, and if you have a chronic case, you may have to release the ulnar sagittal band to allow the tendon to be centralized. Quadriga has to do with the fact that the long ring and small fingers have the same common muscle belly, and so if one of the tendons gets shorter, you will lose excursion of all of the other fingers. Patients will typically present with an inability to make a full fist from incomplete excursion of the uninvolved tendons or inability to fully extend due to tethering of the involved tendon. Patients will complain of weakness in grasp. Common scenarios for a quadriga are a finger amputation where the FDP is sewn to the extensor to provide padding for the tip that limits the amount of excursion of that one specific tendon and also of the adjacent tendons with the same muscle belly. Other scenarios are scarring of the profundus tendon after trauma or inappropriate tensioning of a tendon graft. Lumbrical plus finger is paradoxic extension of the finger with attempted flexion. The picture shows you the anatomy of the lumbrical. The lumbrical muscle belly originates from the profundus tendon and then goes to attach the dorsal aspect of the IP joints to provide extension. If there's discontinuity of the flexure tendon and the patient attempts to flex the finger, the muscle belly and the tendon stump will pull the origin of the lumbrical more proximally, thereby affecting extension at the PIP and DIP joints, and that is what gives you the paradoxic extension of the finger with attempted flexion. We talked about intrinsic tightness, the intrinsic tightness test. Intrinsic tightness can occur after strokes and burns. Basically, what you get is inability to flex the IP joints with a metatarsal joint extended. So if the MP joint is extended, it's hard to bend the fingers. If you allow flexion of the MP joints, then IP joint flexion is easier. Tendinopathies, trigger finger or Cmc Tenosynovitis. What you worry about is the structure that's at risk is the radial digital nerve to the thumb because it crosses your surgical field. So whenever you're doing a thumb, you need to find the radial digital nerve and protect it. If you do a percutaneous release, you can score FDS. You need to differentiate trigger finger from a locking MP joint. A locking MP joint will occur when there is degenerative changes in the MP joint with bone spurs. What happens is the ligament, the collateral ligament of the MP joint can get stuck in an osteophyte, and that is what is termed a locking MP joint. The way to differentiate between the two, when you have a locking MP joint, the MP joint is going to be locked in flexion, and the IP joints are going to be straight. If it is your regular trigger finger, it is the IP joints that are flexed. So if your IP joints are not flexed, you don't have a trigger finger. Talked about tendinopathy of the third dorsal compartment, the extensor pollicis longus tendon. As we saw before, about 5 to 8% or somewhere around that vicinity of patients that have a distal radius fracture that is not displaced will eventually present with a rupture of the extensor pollicis longus tendon. Patients will present with an ability to use the EPL tendon or extend the thumb. If patients are affected functionally by this, then the treatment of choice is the transfer of the extensor indicis proprius tendon to the extensor pollicis longus tendon. With regard to tendon transfers, the one tendon transfer that you should try to memorize is the radial nerve palsy transfers. These are typically seen in conjunction with humeral fractures and associated nerve palsies. Basically, you need to repair three things. One is the lack of wrist extension, the second, lack of finger extension, and the third one is the lack of thumb function. As far as the transfers of choice are concerned, for wrist extension, we like to use the Pronator Syndrome, transfer to the extensor carpi radialis brevis. We use the brevis because it attaches onto the base of the third metacarpal, and therefore you get a neutral extension. For EDC or finger extension, we like the flexure carpi ulnaris or flexure carpi radialis. And finally, for the extensor pollicis longus tendon, we use the palmaris longus. In contrast to the case where we have EPL rupture, we don't use the EIP because the EIP is also innervated by the radial nerve, correct? So the EIP is not working either. And that is the way that they will try to trick you. Looking at congenital hand differences, the one that tends to be popular is the radial club hand, which means that there's a partial or complete absence of the radius. You also have deficient thumb, radial carpus, and thenar muscles. Radial club hand is associated with visceral anomalies such as cardiac abnormalities, what is termed Holt-Oram syndrome, thrombocytopenia and absent radius, Fanconi's anemia, and Vater syndrome. Comparing ulnar versus radial club hand, the ulnar club hand has associated hand deficiencies, while the radial club hand has associated thumb deficiencies. The ulnar club hand patients have relatively good hand function, while the radial club hand patients have poor hand function. For radial club hand, the treatment, the goal is to centralize the hand and do a thumb reconstruction. Syndactyly is the most common form of a congenital hand anomaly. It's 1 in 2,000. You can have complete versus incomplete, simple versus complex if it involves bone, most commonly seen in the long and ring fingers. Thumb anomalies, hypoplasia of the thumb is classified by the Blouth classification. Type 1 is a short thumb. Treatment is observation or augmentation. Type 2 is where you have soft tissue deficiencies, ligament muscle contracture. Reconstruction is the way to go. The type 3 is where you have actual tendon and skeletal abnormalities. This is really the crucial point. If your CMC joint is unstable, then you can do a reconstruction, meaning like a free toe transfer. If your CMC joint is unstable, you cannot save that thumb, and therefore removal and pollicization with the index finger is the treatment of choice. Pouce flottant, it's just a very small nubbin of thumb. Those, you remove it and you do a pollicization. And finally, if there is no thumb, you also do a pollicization. Finally, a Madelung's deformity is an abnormal growth arrest of the volar and ulnar aspect of the distal radial epiphysis. You get ulnar and volar tilt of the radius. The deformity is typically not seen until adolescence. Initially, you treat with splinting, and if you need to do surgery, then ulnar shunting osteotomy is the way to go because, again, the ulna is growing normally, so it becomes more prominent in the wrist, or a radial shorting osteotomy or distraction lengthening.
right, in terms of vascular disorders, ulnar artery thrombosis is common. The hypothenar-Hammer syndrome caused by thrombosis of the ulnar artery in the Galeazzi canal. Typically, this will be seen in a laborer from repeated blunt trauma, typically males in their 50s. Lumps and bumps in the hand, mucus cyst of the fingers, very common. If these are excised, there's a very high recurrence rate if the associated degenerative osteophyte is not removed along with the cyst. A glomus tumor is found at the distal end of the finger, typically and characteristically under the nail bed. There can be a blue or purplish appearance underneath the nail plate, and patients have pain and, in particular, cold intolerance. Treatment of glomus tumors is with marginal excision. Giant cell tumors of tendon sheath are firm, slow-growing mass, more common distally in the digits and on the volar side. Soft tissue tumors, epithelial sarcoma, the most common soft tissue sarcoma of the hand. It's frequently misdiagnosed. Squamous cell cancer, the most common cancer, most common malignancy of the hand. Dupuytren's disease is caused by a contracture from the myofibroblasts. It's associated with an increase in type 3 collagen. Treatment indications include greater than 30 degrees of contracture at the MP joint and any degree of PIP joint contracture, particularly when associated with progression or functional limitations. The spiral bands, which pass dorsal to the neurovascular bundle, place the neurovascular bundle at injury, at risk for injury. Cleveland's ligaments, again, the sealing or dorsal ligaments are not involved, and the spiral cord, which is formed by the pretendinous band, the spiral band, Grayson's ligament, and the lateral digital sheet tend to draw the neurovascular bundle into a proximal, midline, and superficial position with increasing degrees of contracture. Skin grafts are appropriate as long in conditions where there's no exposed tendon or bone or when there is intact paratenon. Full thickness skin grafts are typically used for defects in the palm of the hand because they tend to contract less and have better reinnervation potential, but our downsides include a higher infection rate and decreased survival than the split thickness skin grafts. Split thickness grafts are typically used for defects on the dorsal aspect of the hand where we're not as concerned about contractility or sensibility, and we can cover more area if the grafts are meshed. Looking at flaps, Z-plasty, the most important factor is keeping all limbs of equal length. Cross-finger flaps are used to cover palmar defects of an adjacent digit. V to Y advancement flaps are used for characteristically for dorsal defects of the fingertips. The Moberg flap is indicated for the thumb, and the dorsal metacarpal artery flap is used for coverage of the dorsum of the thumb or digits. In replantation, sharp injuries are better than crush injuries or avulsion injuries in terms of the survival, and the mechanism of injury is the most important determinant of survival. Muscle is the critical factor in determining ischemia time. Warm ischemia is less than 6 hours for proximal amputations and less than 12 hours for amputations distal to the carpus because of the decreased muscle. Cold ischemia, less than 12 hours proximal and less than 24 hours distally. Indications for replantation, best indications are the thumb, multiple digits, and kids. The order of repair for fingers, bone, extensor tendon, flexor tendon, artery, nerve, vein. If there are multiple fingers involved, remember to do the structure by structure technique as opposed to digit by digit. Management of the failing replants depends on the etiology. If it's an arterial inflow issue, the first step is to release the wound dressing. If it's a venous outflow issue, first step is to improve venous outflow, which can involve the use of leeches. Leeches can lead to Aeromonas infection, and that should be covered with fluoroquinolone. Some examples of flaps and their arterial supply. This is generally what they'll ask you about. The free flaps, pedicled flaps. The posterior interosseous artery flap is based on the posterior interosseous artery and feeders from its subcutaneous perforators. The lateral arm flap is supplied by the posterior collateral radial artery, and the vascularized fibula is based on the perineal artery. For coverage of tibial wounds, proximal third tibial wounds are covered by the gastroc rotational flap based on the sural artery. Middle third, soleus rotational flap, and distal thirds require free tissue transfer. The anatomy of peripheral nerves involves the endoneurium, which is the loose collagen matrix around the individual fascicles, the perineurium, which provides the blood-nerve barrier and protects the nerve during stretch and compression injuries, and the epineurium, which is the outer layer and responsible for the tensile strength and elasticity of the nerve. Quickly adapting receptors, which are sensitive to vibration and threshold testing, are Pacinium corpuscles. Meissner's corpuscles are measured by moving two-point discrimination, and that's a measure of the quickly adapting fibers. And static two-point discrimination, or Merkel's receptors, are measured with light touch or static two-point discrimination, and they're a measure of the slowly adapting fibers, and that's a measure of innervation density. As a general concept, if nerve dysfunction occurs after a sharp injury, a laceration, or stab wound, those should be explored. The nerve is likely to be disrupted. If there's a nerve injury after a blunt injury, such as a low-velocity gunshot wound or a closed fracture, they should be observed, as it's likely to be a neuropraxia, and EMGs can be performed typically 3 to 5 weeks post-injury to assess this further. Nerve conduction studies test only the large myelinated fibers. EMGs are based on the spontaneously active findings in denervated muscle, but again, this appears generally after about 3 weeks after the injury. For acute nerve injuries, you'll see fibrillations and sharp waves on the EMGs. Carpal tunnel syndrome is the most common peripheral nerve compression. The carpal compression test is the most sensitive physical exam finding for this. Initial treatments include splinting the wrist in a neutral position, cortisone injections, which have very high short-term success rates, but risk intraneural injection, and typically the relief of symptoms is short-lived. Open release of the carpal tunnel is commonly performed. The most common cause of failure is incomplete release of the transverse carpal ligament, and this is generally at the distal edge. If patients are presented to you who have continued or progressive weakness after carpal tunnel release, but they have improvement in their sensory symptoms, this may be due to failure of release of a transligamentous motor branch, and generally after open carpal tunnel release, grip strength returns by 12 weeks postoperatively. In Pronator syndrome, the median nerve is compressed more proximally in the forearm by 4 structures, by one of 4 structures: the ligament of Struthers, the Lacertus fibrosus, the 2 heads of the pronator, or the origin of the FDS. Initial treatment of cubital tunnel syndrome is by splinting the elbow in a position of mid-flexion. 45 degrees with the forearm in neutral rotation decreases the pressure in the cubital tunnel most optimally. A lumbrical block splint can be used if there is significant intrinsic weakness with clawing. And there's been shown to be no difference in surgery, no difference in outcomes in the various surgical treatment types, including decompression, medial epicondylectomy, and transposition. But regardless of surgical treatment, the medial antebrachial cutaneous nerve is the structure most at risk during the surgical dissection. If a transposition is performed, remember to remove the medial intermuscular septum, because if not, that can be a source of iatrogenic compression. The distal ulnar tunnel, Guillen's canal, is divided into 3 zones. Zone 1 is proximal to the nerve's bifurcation and involves both motor and sensory symptoms. Zone 2 involves compression of the deep motor branch, and Zone 3, the superficial sensory branch. The most common cause of compression in Guillen's canal is ganglion cysts. Commonly, thrombosis of the ulnar artery in Zone 3 causes sensory symptoms. And again, treatment similar to carpal tunnel. For radial nerve injuries in the humerus, the best indications for nerve exploration are open fractures. There's a very high rate of concomitant nerve laceration. Palsies after surgical fixation or fracture reduction are more controversial. If there's no return of function after an appropriate waiting period, typically 6 months or so, that's a reasonable indication for exploration. Acceptable positioning in Distal radius fractures include within 20 degrees of normal tilt, in other words, less than 10 degrees of dorsal angulation, or on articular incongruity of less than typically 2 millimeters. If there's significant disruption of the articular surface, that's a poor prognostic factor in distal radius outcomes. In cases of malunion, osteotomy with bone graft and internal fixation can be performed. Remember, there's a high incidence of osteoporosis in patients with distal radius fractures. Vitamin C has been suggested to reduce the incidence of CRPS, and acute carpal tunnel syndrome after distal radius fracture or internal fixation is a surgical emergency and requires an immediate carpal tunnel release. For non-displaced fractures, there can be EPL rupture, which can occur with time. And again, surgical treatment for this is the EIP to EPL tendon transfer. For forearm fractures, many ulnar shaft fractures can be treated non-operatively. Radial shaft fractures are typically treated surgically. Surgical fixation of both includes use of a 3-5 plate and 3 screws above and below the fracture site. Remember to watch out for the DRUJ and assess it carefully post-operatively or intraoperatively to make sure that the DRUJ is reduced, stable, and congruent. In cases of both bones forearm fractures, fixation of both bones should be performed through separate incisions. For the radius, the distal and middle third fracture of the radius should be approached through a volar Henry approach. Proximal fractures should be approached through a dorsal Thompson's approach. Single incisions for both bones forearm fractures increases the risk of synostosis, which can be treated with excision and X-ray therapy and NSAIDs. Bone graft, remember, is indicated for segmental bone loss in forearm fractures, not for the degree of comminution. Significant bone loss greater than 6 to 8 centimeters necessitates the use of a vascularized fibula. For those proximal third radius fractures, the posterior interosseous nerve is most at risk of injury. In treatment of Galeazzi fractures, the reduction of the radius must be anatomic. If the DRUJ reduces and it is stable, the arm can be immobilized for 4 to 6 weeks. If it is not reduced or unstable, a closed or open reduction followed by pinning or repair of the Tfcc can be performed. The forearm is typically immobilized in supination for 4 to 6 weeks, and the most common structure blocking reduction is the extensor carpi ulnaris. Similarly, in ulnar shaft fractures with radiocapitellar instability or Montesia fractures, the reduction of the ulna must be anatomic to ensure reduction of the radiocapitellar joint. If that's not reduced, first step is to assess the ulnar reduction. If that's adequate, then the radiocapitellar joint can be reduced open. It's typically then stable and early motion can be performed. In type 1 Montesia fractures, where the injury and dislocation is anterior, the anterior interosseous nerve is the most characteristic associated injury. Posterior dislocation of the radiocapitellar joint and posterior angulation of the ulna, the type 2 fracture, is typically associated with a posterior interosseous nerve palsy.
All right, just to close up, scapholunate ligament tears. Remember, the scapholunate ligament is critical in the mechanics of the wrist joint. If this ligament is torn, which most commonly occurs off the scaphoid, what happens is that leads to a pattern of DC deformity and eventual carpal collapse and arthritic changes. If you get an acute rupture of the ligament within 6 to 12 weeks, you can fix these with a suture anchor and pins. If you get a subacute, where the interval between the scaphoid and the lunate can be reduced, at that point you can either do a tendon reconstruction with free tendon graft, or what is termed a capsulodesis, which is a reconstruction with local capsular tissue. Finally, in cases where it's a chronic tear, in the absence of degenerative changes, but where you cannot reduce the diastasis between the scaphoid and the lunate, in those cases, an intercarpal fusion is the way to go. Mid-carpal instability is a non-dissociative type of instability. Basically, it reflects instability of the proximal aspect of the capitate on the lunate. Patients are typically young, ligamentously lax. They typically complain of a clunk when they move their wrist from ulnar to radial deviation. On examination, if you place the wrist in neutral with the forearm pronated and you apply stress on the joint, as you go from radial ulnar deviation, you will feel a clunk, and that clunk is really the subluxation of the capitate head on the lunate. In most patients, benign neglect is the way to go, but if you have someone that is symptomatic, not responding to conservative treatment at that point, then either the thermal shrinkage, which is highly controversial, versus the more accepted yet much more invasive and salvage type procedure would be a partial capital lunate fusion. As far as Tfcc tears, there are two types. There's the traumatic type and the degenerative type. Either way, initial treatment for these injuries is immobilization for about 6 weeks or so. If you have a traumatic tear and they don't respond to conservative management, at that point treatment is with arthroscopy to either repair or debride the tear. If you have a degenerative tear and there is evidence of ulnar carpal degenerative changes, at that point a distal ulnar excision or a ulnar shortening osteotomy will help to decompress the compartment. Looking at the thumb MP joint, the primary stabilizers of the metacarpophalangeal joint of the thumb are the collateral ligaments. The collateral ligaments originate from the metacarpal head. There are two parts. One is the accessory, which attaches onto the volar plate there. Then you have the proper, which is bone to bone. Remember that ligaments are lax in extension and taut in flexion, and as such, the testing should be done with the joint in some degree of flexion. The thumb metacarpal joint, most dislocations are dorsal. The dorsal radial ligament is the primary stabilizer to dorsal dislocation. Even after you reduce them, most remain unstable, and at that point you need to either pin them or do a primary ligamentous reconstruction. This is controversial, but I would answer ligament reconstruction if I was asked. If you have a chronic instability, then reconstruction with an FCR is the treatment of choice. To Kevin's, this is thumb metacarpal fracture dislocation. This is the Bennett's type fracture. There are several deforming forces on this injury. This is the adductor muscle, and the adductor attaches on the metacarpal and brings it into adduction and some supination. And here you have the abductor pollicis longus, which is proximally distracting the metacarpal on the rest of the thumb. That's why these injuries are so unstable, because there are muscle forces distracting them, and that's why you need to address them surgically with either pinning or internal fixation. We talked about fracture dislocations of the proximal interphalangeal joint. Remember that the key for success in these injuries is reconstruction of the articular segment, meaning anatomic reduction of the condyles of the proximal phalanx onto the articular surface of the middle phalanx. Of secondary importance is the articular surface congruity. Treatment is either dorsal block pinning, internal fixation if you have a large fragment, or a volar plate arthroplasty if it is a more chronic condition. The stability of the PIP joint really has to do with the amount of fracture that you have in the base of the proximal phalanx. Most of the collateral ligament origin is here, and most of the ligament attaches to the bottom 50% of the joint area. So if you have a fracture that involves more than 50%, this is going to be grossly unstable, because the entire ligament complex is now attached to the piece of bone that is fractured off. Again, this is an example. Remember, we talked about the dorsal cortices of the phalanges being collinear. Here you have a significant step off, and again, this is a PIP joint fracture dislocation that needs to be treated surgically by restoring the articular alignment. As far as osteoarthritis of the distal interphalangeal and proximal interphalangeal joints, the enlargement of the joints termed Heberden's nodes. In addition to the osteophytes, you can have what are termed mucoid cysts. Mucoid cysts are cystic prominences from the joint that are associated with an osteophyte. If you do surgery on these to remove the mucoid cyst, you need to remove the bone spur as well to diminish the likelihood of recurrence. If you have a patient that requires surgical intervention for DIP joint arthritis, the treatment of choice is arthrodesis and a little bit of flexion, about 10 to 20 degrees, to preserve their capacity for flexion. If you use a headless compression screw, you have the highest success rate in terms of achieving union. The PIP joint, the treatment of choice is also arthrodesis, and you also want to apply a little bit of flexion to allow patients to grab things. Typically start at about 30 degrees on the index finger and progress to 45 degrees in the small finger to provide greater flexion. If you have an older debilitated patient or a rheumatoid patient, or if it is a patient in the non-bordered digits, you can consider arthroplasty in the form of either silicone arthroplasty or pyrocarbon arthroplasty. But for test-taking purposes, I would answer arthrodesis. Thumb Cmc Joint Arthritis. It is the most common joint in the hand that requires surgery for arthritis. This is due to pathologic laxity of the primary stabilizer, which is the volar beak ligament. Treatment includes splinting, anti-inflammatory medication, corticosteroid injections. In cases that fail and have significant symptoms, then surgery can provide relief. All surgical interventions involve trapeziectomy, and there's variants including nothing plus or adding a pin or adding a tendon reconstruction. Scapholunate advanced collapse is a predictable progressive pattern of degenerative changes in the wrist that occurs as a result of a scapholunate injury that leads to the DC deformity or carpal collapse. The stages of the disease, stage 1 is where you have degenerative changes between the radial styloid and the scaphoid. In these cases, patients can be treated with an excision of the radial styloid, plus minus an intercarpal fusion to prevent progression of the collapse. Stage 2 involves involvement of the entire scaphoid fossa on the radius with the scaphoid. When you get to this point, the scaphoid has to be removed. In addition to removing the scaphoid, your choices are also to remove the lunate and the triquetrum, what is termed a proximal row carpectomy, or you can excise the scaphoid and then do fusion of the capitate, lunate, triquetrum, and hamate. Stage 3 is where you get proximal migration and degenerative changes in the articular surface of the capitate. Because that surface is now arthritic, you can no longer do a proximal row carpectomy, because if you did that, now you have an arthritic capitate head articulating on the radius, which is likely to generate ongoing pain. So whenever you have a type 3, the choices are either excising the scaphoid and then fusing the 4 bones, or doing a total wrist fusion. Finally, the last stage, pancarpal arthritis. In those cases, fusion is the only way to address the symptoms. Inflammatory arthritis, gout, is the crystalline arthropathy, which is due to the deposition of monosodium urate crystals. These crystals lead to an inflammatory response. These needle-like crystals are negatively birefringent on polarized microscopy. These can lead to severe joint degeneration, especially at the DIP joint. Gout in the hand is a great mimicker of infection, so you always have to have that as your differential diagnosis. And in the hand, you can also see deposition of gouty tovus. Moving on to rheumatoid arthritis and tendon ruptures. The most common form of extensor tendon rupture, attritional in nature in patients with rheumatoid arthritis, is what it's termed the Vaughan-Jackson syndrome. What occurs in the Vaughan-Jackson syndrome is that inflammatory changes at the distal radio-ulnar joint create synovium that can infiltrate the overlying tendons. It can also create significant instability of the joint to the point where the ulnar head can be very prominent, and as such, creates sort of a rough area where the tendons travel, and as such, lesser finger tendon, extensor tendon ruptures are common. Again, this is called the Kaput-Olney syndrome. Treatment for the Kaput-Olney syndrome include tendon reconstruction, whether either side-to-side transfers or EIP transfers, and if the ulnar head is a problem, at that point either excision or reconstruction form for the DRUJ to prevent ulnar prominence is the treatment of choice. Similar to osteoarthritis, rheumatoid involvement in the interphalangeal joints is also treated with arthrodesis with some flexion, or in the DIP joint. And in the DIP joint, you can consider joint replacement in older patients that are with less functional demands. But finally, the last topic is infection. Remember that one way to organize these infections is through patterns of infection. If you have a regular community-acquired infection, like a work or home infection, those are typically gram-positive organisms. The most common type would be a Staph aureus infection, although over the last several years, we've seen an increase in the incidence of community-acquired methicillin-resistant Staph aureus infections or MRSA infections. Diabetics, patients that have injuries in farm or soil or bites or IV drugs, these infections have a higher propensity to be polymicrobial, have gram-negative presence. IV drug abscesses tend to have Staph aureus and strep. Again, IV drug abusers have high incidence of MRSA infections. If you have a chronic indolent infection, you need to think about mycobacterial infections such as Mycobacterium marinum. As far as staining, for routine staining, aerobic, anaerobic, and gram staining should be done. If you're suspecting an atypical mycobacterium, then you have to culture them in low temperature using a Lowenstein-Jensen medium using Zeal-Nielsen staining. If you suspect spirotrichosis, a fungal infection, then you should do a potassium hydroxide prep. Finally, if you're considering herpetic whitlow, then a Zank smear is the way to go to look for giant cells. Infection of the flexure tendon sheaths, Flexure Tenosynovitis, is diagnosed using Canavel's 4 cardinal signs. 1 is a flexed posture of the affected digit. 2 is tenderness along the flexure tendon sheath. 3 is the sausage finger or diffuse circumferential swelling. And finally, passive extension of the flexed finger can lead to a significant amount of pain. Human bites are typically due to fist fighting injuries. Initially, as far as structural disruption is concerned, they may seem innocuous because of the different planes of injury when the hand is held at full flexion. A wound over the MCP should be considered intra-articular because it can be difficult to see with the overlying tendon intact. For animal bites, dog bites are more common than cats or rodents, although cat bites tend to be worse because their teeth are sharper and create more tissue penetration. Pasteurella multocida is the most common organism seen in these injuries. These typically require irrigation and debridement and treatment with broad antibiotic coverage, such as Augmentin or Unison. 75% of all mycobacterial infections are in the hand, and of these, Mycobacterium marinum is the most common. Typically, you will see it in the setting of a marine, lake, or aquarium type environments. This organism inhabits both salt and fresh water, and the onset of presentation from the time of injury or exposure to the time of presentation can be over 6 months. As far as viral infections, herpes simplex virus are most common, and what is this termed herpetic whitlow, most often seen in the fingertip. I need to make sure you don't confuse it with a felon, because if you do an irrigation and debridement, you can create systemic spread of the virus. The most common folks that are involved in these injuries are healthcare workers, such as dental hygienists and kids, toddlers. That's it. Thank you very much. Good luck.